Order. I will call Sarah Hall to move the motion, and I will then call the Minister to respond. I remind other members that they may only make a speech with prior permission from the member in charge of the debate and the Minister. There will not be an opportunity for the member in charge to wind up as a convention for 30 minutes debate. Order, order. Sarah Hall to move the motion.
Thank you, Ms Butler. It is an absolute pleasure to serve under your chairship this morning. I want to begin by dedicating my remarks to my constituents Joanne, Gavin and their daughter Ibby, who is 2 years old. Ibby lives with a rare and serious condition called Congenital Hyperinsulinism, a term many won't have come across, but one that has come to define every part of life for the families that it touches. Congenital Hyperinsulinism, or CHI, affects around 95 babies born in the UK each year, with just over 2,000 people currently living with the condition. It causes the body to produce too much insulin, leading to dangerously low blood sugar levels. Left undiagnosed or unmanaged, the consequences can be life-altering, increasing the risk of long-term neurological complications and impaired neurodevelopment. The clinical challenges are complex, and the emotional toll on families is enormous. When I met Ibby recently at one of my constituency surgeries, I met a bright, smiling 2-year-old full of life. But behind that smile is a reality her parents face every single day. Managing risk, navigating a system that too often doesn't understand their daughter's condition, and fighting for basic support. And while the challenges she faces in living her life are many, her parents, Gavin and Joanne, are doing everything that they can to help navigate them. Joanne and Gavin are both teachers, a maths teacher and an English teacher, but they can't work. Ibby's needs mean that they must always be close by. They must always have access to a car, and they cannot be a one-car household. Every family decision, no matter how small, is shaped by proximity to emergency care. Their other children have also been drawn into the experience. They've learned how to spot signs of danger. They've been taught to perform heel pricks. The whole family has stepped up to help keep their baby sister safe and well. It's clear that congenital hyperinsulinism is not just a medical diagnosis, it's a whole life diagnosis. Yes, absolutely.
First of all, can I commend the Honourable Lady for bringing this forward and declaring interest as a type 2 diabetic, not just as bad, I have to say, but still one that has to be managed. Does the Honourable Lady not agree that with Northern Ireland, for example, having a high prevalence of diabetes with almost 115,000 people living with the condition and that number increasing annually, it is essential that early intervention for those who are pre-diabetic is essential, and consideration must be given to widen the ability for Ozempic and Mounjaro and other GLP drugs to be prescribed more widely to help the prevention of full-blown type 2 diabetes. And this needs to be done not just in the Honourable Lady's constituency or in my constituency, but indeed across this great United Kingdom of Great Britain and Northern Ireland. Thank you.
Thank you. And the Honourable Member makes a very important point. The children have been drawn into this experience, the other children in the family, and they've learnt how to spot signs of danger. The whole family has stepped up to help keep their baby sister safe and well. It's clear that congenital hyperinsulinism is not just a medical diagnosis, it's a whole life diagnosis. It affects emotional health, finances, education, work, family life and more. And far too often, families say they feel invisible, left to navigate this journey alone. To personally train the staff, to teach them how to carry out a heel prick, how to spot signs that Ibby might be unwell. What should have been a joyful milestone becomes a period of anxiety and worry. Even basic medical information for them is hard to access. After Ibby was diagnosed, her parents weren't given guidance on how to manage the condition. No education, no tools, no support. Even their GP and health visitor was unfamiliar with CHI. They had to travel from Warrington to Alderhay in Liverpool just to ask if Ibby could take Calpol. DLA forms have been difficult to complete. There is no easily accessible support and little knowledge of the condition. All of this compounds what is already an extremely worrying situation for families and results in many feeling isolated and lonely. That kind of gap in care is not just inconvenient, it's dangerous. It speaks to a wider failure to provide families with the knowledge and resources that they need. I want to thank the Children's Hyperinsulinism charity for helping to bring these issues to the fore. This is a small charity run by dedicated parents who are doing the work that should be supported and in many cases delivered by public bodies. We know the financial burden on the NHS is considerable. A 2018 study found that congenital hyperinsulinism costs the NHS over £3.4 million per year. That's why early diagnosis, consistent care and good support systems are not just good practice, they're essential and they're cost effective. Yet across the country, parents are telling us the same story. Late diagnosis, poor awareness, postcode lotteries in care and lack of access to vital medication and monitoring technology. Gavin and Joanne had to fight to get a continuous glucose monitor for Ibby, a tool that allows real-time blood sugar readings and could prevent neurological damage. They succeeded, but the funding only lasts for a year, and after that, they're back to square one. And while some hospitals like Alderhay, Royal Manchester Children's Hospital and Great Ormond Street offer specialised support, families who live outside those areas are left with fewer options. Geography should not determine the quality of healthcare that a child receives. As it stands, congenital hyperinsulinism is not even listed on the NHS website. That is a small but symbolic gap, and it makes a difficult diagnosis even more isolating. There are misconceptions about the condition. Comments from health professionals to my constituent include, "Is that like diabetes?" when they are told about Ibby suffering from hyperinsulinism. Improving clinical understanding of CHI is essential. At present, no routine test for the condition is carried out in newborns. The standard heel prick screening, familiar to most parents, does not check for hyperinsulinism. For families like Gavin and Joanne's, early diagnosis came not through systemic checks, but chance. Their daughter Ibby was seriously unwell at birth, which prompted further testing and led to the diagnosis, but others are not so fortunate. Many children with the condition show few symptoms initially, and diagnosis only follows a serious health episode. In too many cases, it is not clinical vigilance that identifies the issue, but emergency. This unpredictability is compounded by geography. Families describe a postcode lottery in access to timely treatment and care. In Ibby's case, even medication is not easily obtained in Warrington. Her parents must travel to Alderhay, where she is able to receive the specific brand that she requires. For a family already managing a complex health condition, this adds further pressure and strain. Now, I want to conclude with some specific asks drawn directly from the lived experience of families in my constituency and beyond. Number one is to ensure congenital hyperinsulinism is added to the NHS website as a priority to raise awareness with healthcare professionals, caregivers and the general public. Two, to work with families, charities and health professionals to create an information campaign and resource pack for parents and other frontline health professionals. Three, to guarantee equitable access to treatment, medication and monitoring technology, including CGMs, regardless of geography or condition type. Four, to provide more consistent support with benefits processes like DLA, where families currently face a wall of bureaucracy and misunderstanding. Five, to address disparities in access to key medications like diazoxide and work to prevent supply shortages. Six, to fund ongoing research into treatments to reduce the need for invasive procedures like pancreatectomies. And finally, I asked the Minister to meet with the families affected by hyperinsulinism, including Gavin and Joanne, to hear directly from them and to explore how government can close the health and care gap. Ms Butler, in closing, I want to return to the heart of this debate. Not just a medical condition, but the families whose lives are shaped by it. People like Gavin and Joanne and their daughter Ibby, whose story reminds us that behind the terminology and statistics are children who deserve the chance to thrive and parents who deserve to feel supported and not abandoned. We must not accept a healthcare system where your postcode determines the standard of care your child receives. Nor should we tolerate a lack of basic awareness among professionals about a condition with such serious implications. When families are educating their GPs and nursery staff on how to manage their child's condition, something is wrong. Every child deserves that same level of care, and every parent deserves the reassurance that the system is there to support them. Families like Ibby's aren't asking for the world. They're asking for recognition, understanding, and a system that helps them to do what they already do so well, love and care for their children. We owe them that and more.
Thank you. The question is that this House has considered the impact of congenital hyperinsulinism on patients and their families. Minister.
Thank you very much, Ms Butler, and it's a real pleasure to serve under your chairship today. I'd like to start by thanking my honourable friend, the member for Warrington South, for securing this important debate. It really is a tribute to her and also to her constituents, to Ibby and her family, who've clearly been through a very challenging time, but have shown tremendous strength and bravery and love and compassion. And I would very much be grateful to her if she could pass on our very best wishes to the family and to thank them for helping us to look at this issue today. The birth of a new member of the family should be a moment of excitement and celebration and indeed exhaustion. Realising your baby might have a serious illness should be the last thing on any new parent's mind. And that's why getting help quickly is so important, as is ongoing support. Around 95 children are born with congenital hyperinsulinism in the UK each year. While this means it is a rare disease, it should not be overlooked. This government is committed to improving the lives of people living with rare diseases. And on that point, I have carefully noted the 7 asks, I think, that my honourable friend had at the end, including one ask for the relevant minister to meet. I should say that the actual lead minister in this area is our colleague, the Minister of State for Health, and she's not present here today. I'm standing in for her, and I will absolutely be passing, my officials are here, will pass on all of the asks that my honourable friend had, and indeed also the ask for a meeting, and I'm sure my colleague, the Minister for Health, will be happy to follow up on those points. Rare diseases like congenital hyperinsulinism are individually rare but collectively common. With over 7,000 rare conditions, 1 in 17 people will be affected by one over their lifetimes. Each condition will have different symptoms and experiences, and every person is unique. Despite that, there are challenges that are shared across all rare diseases. These challenges have shaped the approach of the UK Rare Diseases Framework and England's annual action plans. The National Conversation on Rare Diseases in 2019 identified 4 priorities for the framework: ensuring patients get the right diagnosis faster, increasing awareness of rare diseases among healthcare professionals, better coordination of care, and improving access to specialist care, treatment and drugs. I will give way.
For giving way, and can I also congratulate my honourable friend on securing this very important debate. I hadn't actually intended on intervening, but some of the issues that were being raised by my honourable friend were very similar to issues I've had in my own constituency around young boys who are diagnosed with Duchenne muscular dystrophy and are having difficulty accessing the drug Juvenostat in Scotland. Can I ask the Minister, obviously I'm aware he might not be able to respond immediately, but if he's able to meet with me to discuss access to that drug in Scotland, how we can help, again, other young people who are affected by a rare disease. Thank you.
I thank my friend for that intervention and absolutely happy to look at that. Clearly devolved in Scotland, but I think there's a huge amount that all the nations of the United Kingdom can learn from each other. Nobody has a monopoly on good ideas, and it would be excellent, I think, to find out a little bit more about the issues that he refers to. These priorities form the what we do and are supported by underpinning themes, the how, if you like, of how we get there. These themes including keeping the patient voice at the heart of all we do, and I'd like to pay tribute to advocacy groups like the Children's Hyperinsulinism Charity and Genetic Alliance UK for their excellent work, supporting families and continuing to raise important issues that help make things better for people with congenital hyperinsulinism. In England, we published the 4th Rare Diseases Action Plan on the 28th of February, otherwise known as Rare Disease Day. This action plan updates on progress made since the beginning of the framework in 2021, and I'm pleased to say it also includes 3 new actions for the future. These actions aim to improve coordination of care, make things easier for families needing to visit multiple specialists, and improve the environment for carrying out research on rare diseases in the UK. Receiving the right diagnosis as soon as possible is vitally important, particularly for conditions like congenital hyperinsulinism that present in infants and young children. Currently, the Exeter Genomics Laboratory is the national provider of hyperinsulinism, HI, genetic testing and the Research Centre of Excellence. The Exeter NHS Genomics Lab, the paediatric endocrinologist community and highly specialised service units have a very close relationship, so patients can be diagnosed rapidly and managed effectively via this multidisciplinary team framework. A diagnosis means the right treatment can be given early, ultimately helping to improve health outcomes. Advances in genomics represent a huge opportunity in finding children with rare diseases as soon as possible, with the Generation study commencing last year. The Generation study, run by Genomics England, is piloting using whole genome sequencing in newborns to identify over 200 rare conditions, including congenital hyperinsulinism. This study is now underway and recruiting across 18 NHS trusts, aiming to screen 100,000 babies. However, diagnosis is only the start of managing a rare disease, and I know that there is still unmet need. Too many people continue to struggle with challenges, including access to reliable information or to specialist treatment. Only 5% of rare conditions have an approved and effective treatment. This is a shocking statistic. To improve this, pioneering research is another underpinning theme of the UK Rare Diseases Framework. NICE's Highly Specialised Technologies HST programme evaluates technologies for very rare and often very severe diseases. We're working with the regulatory system to look at access schemes like the Early Access to Medicine Scheme, the Innovative Licensing and Access Pathway, the Innovative Devices Access Pathway, and the Innovative Medicines Fund. These are all designed to support innovative treatments being available to patients who need them earlier, and they must also work for rare diseases. We know that many people also struggle to access reliable information on rare diseases. With over 7,000 different rare diseases, often needing highly specialised input, the NHS website is not always the best place for this. However, I do note my honourable friend's point about the website, and we certainly will look at that. However, we know that patient organisations and charities play an important role in creating high-quality information on rare conditions. Therefore, in this year's action plan, we've set out steps that we're taking to support organisations get the information they produce accredited under the Patient Information Forum's PIF tick scheme. That way, families will know that they can rely on trustworthy information. Living with or caring for someone with a rare disease can be mentally tough. We know that people living with rare conditions and their families and carers often struggle to access mental health and psychological support. This is not right. Alongside wider steps we're taking to improve mental health access, the NHS Genomics Education Programme has this year published new resources on rare diseases and mental health aimed at healthcare professionals. It has also developed a communications tool to help healthcare professionals with sensitive conversations, ensuring patients and families feel supported in the diagnosis of a rare condition. So I'd like to close by once again thanking my honourable friend, the member for Warrington South, as well as those affected by congenital hyperinsulinism and organisations which advocate on their behalf. While the 5-year UK Rare Diseases Framework comes to a close at the start of next year, we remain committed to improving the lives of those with rare diseases. My colleague, the Minister, will be working with officials and colleagues in the devolved governments to chart a course forwards and to maintain the momentum that we've built. Thank you.
Minister. The question is that this House has considered the impact of congenital hyperinsulinism on patients and their families. As many as are of that opinion, say aye. Of the contrary, no. I think the ayes have it, the ayes have it. Order, order. The sitting is suspended until 2:30.